a clinical pharmacist, and it's a pleasure to be here and meeting you all. And I was asked sort of to share with you my role as a pharmacist. That's what I do in this area. So I'm going to share my presentation in a second, and I tried sort of very hard to stay away from using technical words. Pharmacy has a lot of technical jargon. So just simply say what it is that I do and why sort of I think that it's important for us pharmacists to be involved. Julia, you can see my screen?
We sure can. Everything looks great.
So we all know the traditional roles for pharmacists. In community pharmacy, we see our pharmacists in our corner, neighborhood pharmacies, CVS, Walgreens, and that's a very traditional role that pharmacists have and have had for many years. We're also in hospital pharmacies. In basically this large group of pharmacists who are, typically they are located in central pharmacy, in the hospital pharmacies, in the basement of pharmacies, hospitals. And sometimes depending on the size of the hospital, there are also satellite pharmacies on busy floors in the hospital. There's another very traditional role for pharmacists, verifying medications, making sure the dose is correct, making IV bags and verifying all those, obviously playing very important role. What many people may not be familiar, and I always get that from our patients, get a bit surprised when they see me, is clinical pharmacy. This is nothing new. It's been going on for decades, but maybe a role that not many people are familiar with. So we are in outpatient settings, in inpatient settings, in hospitals. A lot of us, they go to pharmaceutical companies. A lot of pharmacists who work in pharmaceutical companies. Academia is also an important role for us. I am part of academia. I work for University of Illinois, so teaching is an important role again that I play. A lot of us, we go to regulatory pharmacy, FDA. There are a lot of us there. Research, there are many pharmacists who that's all they want to do. And there are compounding pharmacists making drugs, and then drug information is a big area for pharmacists. To do anything other than the traditional roles that I just talked about, you have to do a couple of more years of training, up to 3 years or even sometimes more, depending on which area we're trying to get into. So I am a clinical pharmacist. I'm a pharmacist. I work in an outpatient neurology clinic. And in my role, basically, I collaborate with our neurologists. As Julia mentioned, I worked with Dr. Loeb in his clinic. Our trainees, residents, fellows, our nurses, in any area of our clinic that involves medication. So I know that epilepsy and headache, they're the two major issues for this group, but there are a lot of other conditions in our clinic that obviously a lot of medications are used. So I am involved in any area that we're talking about medications, but again, I know that epilepsy and headaches are big issues, major issues here today. So the reason that pharmacists get involved with epilepsy is just the sheer number of medications that are involved here. Many of you may be familiar with many of these medications, and I have put them in the different boxes because if you look at the first box, these are what we call the first generation anti-seizure medications. And then the second group that came in the market in the 90s, and then the last group, and that list is growing. And it's interesting, looking at when phenobarbital came to the market in 1912, that's a medication that we use today. As old as that medication is, we know how efficacious that medication is, so we still use it frequently even today. So pharmacists can play a significant role here, considering how many medications are involved here. But again, the other reason is that these medications specifically have very different pharmacology and what we call mechanisms of action, the way they work. Some we know work best for some types of seizures and some don't. So for some types of seizures, we have to avoid some of these medications. Some we call them inducers. And what that basically means is that when we combine them with other drugs that the patient is on, they can actually diminish efficacy of other drugs. So for some, it's going to be minor, this interaction is not going to be that significant, but for some, it's going to be very significant. For example, when we think that if we have a transplant patient who's on transplant medication, we have women of childbearing age who are on hormonal contraceptions, we have patients who have other infectious diseases. So for some combinations, we keep a very close eye on the other medication that the patient is taking. And some, we call them, they are inhibitors. So what it means is that when we combine these anti-seizure medications that are considered inhibitors with other drugs that the patient may be taking, they can increase and enhance the concentration of other drugs that can put the patient at risk for adverse events and toxicity. Again, we have to keep a close eye on what we're combining with what medication. Some of these medications can cause allergic reaction, and it has to do with the structure of the drug, with the pharmacology of the drug. And what they have is they have this cross-reactivity, which basically means that if we have a patient who has an allergic reaction to one of these group of drugs, and if we start a patient on a different drug, but structurally they are similar, we can see the allergic reaction again. So we keep that in mind, and we always have to screen for those to make sure that if the patient has had an allergic reaction to one of these drugs in this group, that we avoid the whole group and the future selection of medications. When we combine them together, and for many patients we have to do that, they do interact with each other. So we always have to keep in mind how we are combining anti-seizure medications together. Some have unique adverse events. The list is long, but I just chose a couple here. For example, valproic acid, we know it can cause weight gain. Again, choosing the right patient, the right medication for the right patient. So, and we know that, for example, zonisamide is a medication that causes weight loss. Again, do we have the right medication for the right patient? And then some of these medications have to be avoided if a patient is of childbearing age, and especially if there's planned for pregnancy from the get-go, which medications we have to avoid. So the role for a clinical pharmacist just include patient education. That's a big role that we play. Appropriate use of the medication. How am I going to take this medication? What am I going to expect? What are we going to monitor for? And when am I going to call and seek assistance? So patient education is a major role for pharmacists. And then getting medication history, doing medication history reviews and interviews. The term that we refer to is called medication reconciliation. And there are differences between how we do it in clinic versus the hospital. Many times if a patient is a hospital, one of the initial persons or people that visit that patient's room is going to be, one of them is going to be a pharmacist, just gathering information about what medication is being used. In clinic might be a bit different. One of the first people who sees the patient is the person who does the vital signs, and then we gather information about the patient's prescription. We have a list of obviously medications that we have that has been prescribed for the patient, but many times we just simply, if we don't have an accurate information, we simply just pick up the phone and call the patient's pharmacies, and we just gather the information that we need. And the other role that is important when played is just anticipating, preventing, and monitoring for drug interactions. That's a big one for pharmacists. And we do that by basically assessing what we refer to in pharmacy as pharmacokinetic properties of each drug, which basically in simple terms means the movement of the drug in the body, where it's going to go. So this technical term is divided into 4 different sections. One of them is absorption. How the patient is going to take this medication, how is it going to get it into the body, and how is it going to get absorbed. Obviously, there are differences between if the patient is going to take a tablet versus it's a nasal spray or as an injection. Where is it going to go? And which is the distribution for it. And metabolism is a big one. The drug has to be broken down. And for many of these seizure medications, it uses the liver to get metabolized or get broken down. How this medication is going to leave the body, or the term for it is excretion. How is it going to go excrete from the body? What other medications, as we just discussed, the patient is currently taking? So what other conditions or comorbidities a patient can have that can impact the drug? For example, if you're thinking about how this drug is going to leave the body, excreted, and that's for the organ that the drug uses for excretion, where is this patient's kidney function? So we have medications that do that, and then we always have to make sure that we're monitoring the patient's kidney function. And is the patient an adult or a child? Drug dose and metabolism are so different for children versus adult. They use more drug and they by their size, and they have a faster metabolism compared to an adult or an older patient. Our metabolism slows down as we get older. Is this patient of a woman who is of childbearing potential? And then another role that we play when we consider all of this is to suggest alternatives as we're considering all these kinetics parameters of this drug. And again, overall assisting with medication selection. We also do anticipating, preventing, monitoring for adverse drug reactions. And that is done by assessing the kinetics parameters of the drug as we just talked about. But then there's another term that should be considered, this technical term called pharmacodynamics of the drug, which basically is what is biological response to this drug, and has to do with drug's mechanism of action. What does the drug do? And when we're considering this, we have to consider what if the patient is on more than one drug for this condition, which happens a lot in epilepsy. For example, we have two drugs and both of them can cause sedation. How do we choose the drug? How do we choose our dose? How do we go up on this dose? What is our maximum dose? Two drugs both have levels that are sitting at high end of what we call therapeutic range. So they're sitting at this higher level. What if we have to add a third drug to this combination? What is the relationship of this third drug with the other two drugs with regards to drug-drug interactions and pharmacodynamic interactions? So when we're combining this drug, that again happens in epilepsy quite often, we have to consider all of these things, and that's where the pharmacist can play a significant role. And again, we are a source of drug information for everyone in our settings. Obviously, the role for me and for clinical pharmacists is very different depending on what medical condition we're talking about. My role in epilepsy, is different than headache. The needs of the patients are different. The need of our neurologists and nurses are different. Role of both of these conditions are different compared to other medical conditions. For example, another medical condition that I know is important for this group is just headaches. And we know that there are many over-the-counter options in this area. And the reason that pharmacist plays a role here is then the sheer number of medications that are used for this condition. There are many prescriptions available. For many of them, you might be already familiar with. The class of drugs that we call triptans, a simple example that you might have heard of is somatriptan. There are 7 different medications in this class. They have different formulations. You can take it as a tablet. You can take it as a nasal spray. You can take it as an injection. So every one of them does, although they're similar pharmacologically similar drugs, but when they start working, it's different. When you can repeat this drug if it doesn't work, what side effects you are going to expect and monitor for. How long do they last in the body? All of those aspects of these drugs are different. One drug that is, for example, used when the patient has a severe headaches is this dihydroergotamine. This one drug just has 5 different formulations that the patient can be.
Annie's.
And then in the past few years, there have been at least 8 new products. Management of migraine headaches is significantly changing, and headaches in general significantly changing. That they have come to the market, they have different and new mechanism of actions. I just named some because every time I turn my head and I listen to the news or the TV, I see advertisement about these drugs. They're getting very, very popular, like Ubrelvy, Nortec, Calypta, Aimovig, and more. Each of them has different efficacy. Each of them has, looking at their adverse events profile is different. And then the issue of who the medication can be used for, who the medication should be avoided in. And then interestingly, each insurance provider has a different formulary that we have to follow, that which patient in what circumstances can get this medication first. Means I spend a lot of time just between the pharmacies and our neurologists just figuring this out. So my role as in general in our setting, in a neurologist setting, is assisting with drug selection based on the drug's properties, as we just talked about. And then the patient's characteristics is very important, as I said, that we choose the correct drug for the correct, the right patient. Patient education is an important role that I play, especially when we're talking about medication titrations, especially with epilepsy. And I spend a lot of time getting our patients written medication instruction and schedules to make sure that they have understood the schedule and they can follow it. I follow up on anti-seizure levels when our physicians order those, and then blood screening for specific drugs, medical conditions. I get involved in all those, following up on patients, report the side effects, get phone calls from our patients that they're having this side effect or that side effect, so I answer those. Responding to patients' messages about use of other medication. I get a lot of phone calls that our patients call and say, well, my other doctor is prescribing this medication, can I combine it with this medication that I'm taking for my seizures, etc. I want to use this over-the-counter medication, can I use it? Questions like that. Responding to medication questions from our physicians, nurses, others in our team. And medication access, as I said, luckily in our area, getting medication, having access to anti-seizure medication is not an issue in Illinois where I am, but we spend a lot of time and effort for other medical conditions to just getting the patient access to the medications that are in the market. And how do we sort of address denials? What happens to the patient, or how do we address when the patient is denied the medication? So I got two questions when I was preparing this brief presentation. So I will answer those, and I will be happy to answer any other questions that you might have. One of them was, are there things we should know or ask? So things to consider is, you might already know this, but you always have to know what medications you are using. And if you need a list, you should go to see your physician with a list of your medications, including what you're using over the counter. Many patients don't realize that some of our over-the-counter medication, it have significant interactions with other medications, especially we're talking about anti-seizure medications. So it's always a good idea to just include everything that you're taking and you're going to go see or talk to your physician. Ask for written instructions. When I was preparing for this, I came across that there are actually reports, studies talking about how much information, if you ask the patient after their visit, how much they can recall of important medical condition, how much they retain or how much they recall. So there's something wrong with asking for written instructions when we are talking about changes, when changes are being proposed or discussed. When you're talking about medication titration, how are you going to start this medication, for how many weeks, for how long, the schedule of it, when that's been discussed. Who am I going to call and contact if I need something or something doesn't work or there's an issue with this? And then what to expect and when to expect them. For example, there's the Aimovig is getting very popular for management of migraine headaches. And we know that, it takes up to 3 months for it to start working. So sometimes we get a call from our patient for a month later and they're disappointed because they haven't seen an improvement. Again, that goes back to patient education, but what am I expecting from this medication? When am I going to see results? So all of those are good questions to ask when you're talking to your physicians or pharmacists. The other question was, is the clinical pharmacist someone that we can ask for? So hospitals, most likely they're already on the floors. I mean, I know even in our hospital, the areas, our general medicine areas, our ICU units, some section of it already have 2 or 3 pharmacists already on the floor. So you can always ask to speak with a pharmacist. And even if a patient is on a floor that there is no pharmacist, you can always ask. I said, can I speak to the pharmacist? I have been in the smaller hospitals that mainly pharmacists were in the satellites or in the central pharmacies. They will get calls. Can a pharmacist come up and speak to a patient? So you can always ask to speak to the pharmacist. Clinics might be different. Pharmacists may not be in every single clinic. But I look at our center and where the pharmacists are located. Obviously, they're most likely to be in areas that there are a lot of medications like general medicine. Diabetes is a big one for our pharmacists. Anticoagulation, transplant. I think in our center we have 5 or 6 transplant pharmacists. Oncology, infectious disease, liver, and rheumatologists are areas that are big with medications. There are pharmacists. Neurology is growing. As I look at where my colleagues are across the United States, an area that's growing, and the reason that it's growing, it just expand of medication use for so many different areas in neurology. And then many institutions, including community pharmacists, that you might be surprised to hear that, because we train those pharmacists at the University of Illinois. They have what we call medication therapy management pharmacy teams. So there are a lot of clinical pharmacists at our center at the University of Illinois, but even with that, we do have MTM team. These are a group of pharmacists that are in clinics. They are in a center that are close to one of our pharmacies. But basically what they do, they, in collaboration with physicians, they do medication therapy management, and they take care of patients who are on multiple medications. They have what we call multiple chronic conditions, and they're constantly talking to physicians to see and to make sure that this patient is doing what they need to do. Many times the patients, have difficulties sort of managing their medications. They have technicians, they actually prepare the patient's pill boxes for them. So even if you go to a center and you sit about in this clinic that don't have a pharmacist, you can always ask, is there a therapy management pharmacy team in this center? And can one of these pharmacists contact me, or can I, they're always available and you can contact us. So those are the questions that I received, and that was basically a brief summary as what I do and why there is a role for clinical pharmacists in this as a setting of neurology. What I would be happy to answer any other questions that you guys may have.
Thank you so much for your talk. We really appreciate you more than you know.